Yes, sir. Good morning, everybody. My topic for today's presentation is early laryngeal cancer, the surgical anatomy, workup, and principles of treatment. So, I'll be covering my topic under these headings and going to this incidents. So, according to the Globocan 2020, the laryngeal cancer is the 9th most common cancer in males in Asia, and it is the 11th most common cancer in India. So, larynx, it is an integral part of our body, considering its location as well as function. Any change in the slightest of the derangement of the function can alter the phonation, breathing, swallowing, as well as affect the patient's quality of life. So the most common site of laryngeal cancer is in the worldwide, it is glottis, followed by the supraglottis. In India, it is a combined supraglottis and glottis appearance because most of the patients are presenting in advanced stage of disease. Going to the surgical anatomy, we know that larynx is made up of cartilages, 9 cartilages, and which are stabilized with the help of membranes and muscles. So there are unpaired 3 cartilages and paired cartilages. It extends from the tip of epiglottis to the lower border of cricoid cartilage. Epiglottis is an elastic cartilage which has got a suprahyoid and infrahyoid part divided by the level of hyoid and a petiole. And the thyroid cartilage, which is the largest unpaired cartilage, which fuses at the midline. In female, it is obtuse angle, and male, it is an acute angle of 90 degree. And followed by cricoid cartilage. Cricoid cartilage is the single complete ring, and posteriorly it articulates with the arytenoid. Arytenoids are pyramidal in structure, which has got 2 processes, the vocal process and muscular processes. Vocal processes attached to the vocal ligament. And this coronal sagittal section showing the thyrohyoid membrane connecting the thyroid to the hyoid, and the cricothyroid membrane connecting the thyroid to the cricoid cartilage. So the subsites of larynx are supraglottis, glottis, and subglottis. So in this diagrammatic representation, we can see the parts of supraglottis, the epiglottis, aryepiglottic fold, the arytenoids, the false chords, and the ventricle. Then the parts of the true vocal cord, we can see the parts of the glottis, true vocal cord, the anterior commissure, and mucosa covering the anterior aspect of the arytenoid, and the vocal process, which forms the posterior commissure in the subglottis. So this is the coronal section showing the vestibule of larynx with the vestibular fold, the ventricle, and the vocal fold and subglottic area along with cartilages and membranes. So this we already explained. Supraglottis, which actually develops from the branchial arch 3rd and 4th. And so the ventricle is the area between the false chord and the true chord. Petiole is the small portion of epiglottis, inferior portion of the epiglottis, which attaches to the thyroid cartilage. And the thyroepiglottic ligament is the ligament which connecting between the thyroid and epiglottis. Here you can make out the thyroepiglottic ligament. It is the inferior limitation of the preepiglottic space. We'll be covering to the spaces later. So the blood supply in the supraglottic larynx is mainly through the superior laryngeal vessels, and the lymphatics also drain through going along with the superior laryngeal vascular pedicle and draining into the level 2 and level 3. Glottis, which develops from the branchial arch 6, its parts are already explained. The glottic chink is the area between the 2 vocal cords, which is narrow anteriorly and wide posteriorly. So the vocal cord, which has got a membranous part, that's the anterior 2/3, and the cartilaginous part, posterior 1/3. Coming into the histological layers of the vocal fold, there is stratified squamous epithelium, and the lamina propria again divided into 3 layers: superficial, intermediate, and deep. The superficial lamina propria forms the ringy space, and the vocal ligament is formed by the intermediate and deep lamina propria. and it is over it rests over a vocalis muscle that forms the body. So here is the importance of cover body theory proposed by the Hirano. So the cover is formed by the superficial epithelium along with the superficial layer of lamina propria, and the body is formed by vocalis muscle. So what is the principle is the cover is moving over the body, and it forms the mucosal wave pattern of the typical mucosal wave pattern of glottis. So the submucosal lymphatics is actually sparse in glottis, and the lymphatic vessels from glottis as well as subglottis is passing through the cricothyroid membrane, and it is draining into the prelaryngeal and paratracheal lymph node and into the deep cervical. Subglottis, which derived from the branchial arch 6, it starts from 5 millimeter below the free edge of vocal cord, extend up to the inferior border of the cricoid. Coming to the potential tissue spaces in relation to laryngeal cancer spread, which is compartmentalized according to the embryological development. These compartments actually act as barriers, and this is the principle behind the conservation laryngeal surgery. But we should keep in mind that if the cancer is progressive and if the cancer spread already occurred or already happened on over these compartments, then it will spread through the path of least resistance, that is along these connective tissue planes and vascular pedicles. Coming to the first space, the ringy space, the potential submucosal space, which is limited with the arcuate lines and which is along the free edge of vocal cord. This early laryngeal cancer, sometimes it will be limited to the epithelium. In such a case, we can even treat it with a vocal cord stripping or just subepithelial chordectomy, as the ringy space limit the spread of cancer. Coming into the paraglottic space on it is superiorly limited by the vallecula and array epiglottic fold, and laterally limited with the thyroid cartilage, medially the vestibular fold and quadrangular membrane, and posteriorly by the piriform, and inferiorly by the conus elasticus. This space, the content is thyroarytenoid muscle. So the involvement of thyroarytenoid muscle in this region can lead to vocal cord fixation. And this space involvement can lead to early extralaryngeal spread. So this is the axial view of CT showing normal laryngeal anatomy. The first picture here is the pre-epiglottic space, and this one is the paraglottic space with the thyroarytenoid muscle. Coming to the pre-epiglottic space, it is bounded posteriorly by our epiglottis, anteriorly by the thyroid cartilage and thyroid membrane, and superiorly limited by the hyoepiglottic ligament and inferiorly limited with the thyroepiglottic ligament. It is a fat-filled space, and bilaterally it is communicating with the paraglottic space on either side. Epiglottic cartilage has numerous pores on its surface. So the carcinoma involving the epiglottis can very well enter into the pre-epiglottic space. Coming to the natural laryngeal barriers to the cancer spread, one is quadrangular membrane, conus elasticus, anterior commissure, and vocal ligament. The quadrangular membrane, which is extending from the lateral border of epiglottis to the arytenoid, and it is the lower border is thickened to form the vestibular ligament, and laterally it is related to the paraglottic space. Coming to the conus elasticus, it has two parts, the cricovocal membrane and cricothyroid ligament. The superior part of the conus elasticus thickened to form our vocal ligament, and it is posterior. It is extending from the cricoid cartilage to the thyroid and arytenoid cartilages. So posteriorly vocal process and anteriorly the median cricothyroid ligament. So this is a sagittal session showing the extension of the quadrangular membrane extending from the epiglottis to the arytenoid, and cricothyroid membrane extending from the thyroid and cricoid cartilage to the arytenoid. Again, the anterior commissure tendon is also another barrier. So which is actually formed by fusion of vocal ligament of two vocal cords anteriorly, which is attached to the thyroid cartilage. So the attachment of anterior commissure in males, it is at the midway between thyroid notch and lower border of thyroid cartilage, and females it's at the junction of upper 1/3 and lower 2/3 junction. So it is extending from the thyroid cartilage to the vocal process of arytenoid. And the vocal ligament, we already said it is a thickened cricovocal membrane. It also acts as another barrier for spread of cancer, which allows the forms the body of vocal cord. It forms over the body of vocal cord. It allows the mucosa to freely move over the body of vocal cord. And there are muscles of the larynx, mainly intrinsic muscles and extrinsic muscle. Intrinsic muscle which acting on the vocal cord and laryngeal inlet. And coming to the mucous membrane, the entire larynx is mainly lined by pseudostratified ciliated columnar epithelium. Except the vocal cords, it is lined by stratified squamous epithelium. So the motor supply to the larynx is the muscles are supplied by recurrent laryngeal nerve. Except the cricothyroid, it is supplied by external branch of superior laryngeal nerve. In the sensory supply, above the vocal cord, it is by internal laryngeal nerve, and below the vocal cord by recurrent laryngeal nerve. This is important in partial laryngectomy procedures. So coming to the pattern of spread of laryngeal cancers, this is a landmark study by Pressman. This anatomic study is related to the dissemination of cancer of the larynx. They tried studying the pattern of spread of laryngeal cancer using radioisotopes as well as dyes, and with that they identify the pattern of spread. So the glottic carcinoma, the spread is usually slow and predictable, and the most common site is the anterior half of true vocal cord and anterior commissure. So the glottic cancer, if it is involving the vocal cord, it can superiorly extend into the ventricle, inferiorly extend into the subglottis, or it can involve the anterior commissure. Through the anterior commissure, it can go into the thyroid cartilage, and it can very well go into the paraglottic space. If it is involving the anterior commissure, it can superiorly go into the petiole, inferiorly into the subglottis, and anteriorly through the proles tendon, it can involve the thyroid cartilage and reaches the extralaryngeal spread. So those clinically anterior commissure lesion that may be clinically and endoscopically may be a T1 lesion, but on radiology that may be sometimes T3 or T4 according to thyroid cartilage involvement. So this is the axial CT scan, contrast enhanced CT, which is showing a heterogeneous enhancing lesion on the right side of the glottis. We can see the involvement of anterior commissure and early extralaryngeal spread and the anterior commissure. So supraglottic carcinoma usually remains to its subsides, and the supraglottic carcinoma spreads towards glottic side is actually relatively late. This is because of the anatomical and embryological barriers. The epiglottic carcinoma, suprahyoid epiglottic tumors has got a tendency to spread towards the vallecula and base of tongue. Infrahyoid epiglottic carcinomas has got a tendency to spread into the pre-epiglottic space and anterior glottis. So the supraglottic tumor, if it is epiglottic carcinoma, it can circumferentially involve the array epiglottic fold, the false vocal cord, the petiole part, and the piriform sinus. Inferiorly, it can extend into the petiole portion of the epiglottis, the anterior commissure, thyroid cartilage area, and the anteriorly it can extend into the pre-epiglottic space. The false cord carcinomas, it can superiorly extend into the epiglottis, inferiorly into the ventricle, and posteriorly into the array epiglottic fold and arytenoid. The involvement of array epiglottic fold and arytenoid, which can lead to subsequent involvement of hypopharynx. Ventricular carcinomas usually present as a transglottic at presentation, and there is more chance for a pre-epiglottic space involvement. As I already told, arytenoid and A-fold carcinomas extend into the piriform and postcricoid area, and it has got abundant lymphatics and resulting lymph node metastasis. So coming to the etiology, the most common etiology behind is smoking and alcoholism. So according to the Hashipe et al., the population attributable risk for this habits causing 88% for laryngeal cancer. This of which 52% is due to tobacco alone and 33% is attributable to combined use of tobacco and alcohol. So the relative risk reduction requires at least 20 risk reduction to the level of a never smoker takes at least 20 years. Other occupational toxic agents that may lead to laryngeal cancer: asbestos, polycyclic aromatic hydrocarbon, and wood dust, coal dust, etc. And certain blue-collar occupations, and certain genetic syndromes like Fanconi's anemia and congenital dyskeratosis can also lead to laryngeal tumors. The most common pathology is squamous cell carcinomas, and the clinical presentation. So the larynx, from the clinical signs and symptoms itself, it itself gives an idea regarding the epicenter of the lesion. So in glottic carcinoma, it present early with a voice change. So we should remember of any person with a hoarseness or voice change of more than 3 weeks has to be evaluated. And once with increasing the lesion size, the maximum phonation time will be decreasing. The breathiness and the complaints of aspiration of liquids will start with the when it starts affecting the vocal cord mobility. There will be this progressive dyspnea, stridor, and all associated with advanced lesions. Otalgia, dysphagia, oteinophagia associated with most of the time with the advanced lesion. Neck nodes are mostly rare in the early laryngeal cancers. Supraglottic carcinoma, the voice quality alteration is different. It usually presents with the globus sensation or foreign body sensation. And it can even present with a hemoptysis if it is an exophytic tumor. And in case of large lesion, it can present with a hot potato voice. With the involvement of glottis, patients may present with hoarseness of voice. Referred otalgia, oteinophagia, true dysphagia, and all presents towards the with the advanced lesion involving the hypopharynx. And supraglottic cancer can very well present as a neck lump, and during the evaluation, we may end up in finding a supraglottic lesion. Subglottic carcinoma, the clinical features, the symptoms will be vague, just like feeling of globus or foreign body sensation. It can even present with a progressive dyspnea and stridor, with a rapid vocal fatigue. And the direct extension of subglottic cancer into the thyroid, through the thyroid, can mimic thyroid isthmus lesion. And we should not omit the neck examination. We should look for the, even if it is an early laryngeal cancer, we should see for the laryngeal framework, any widening, presence of laryngeal crepitus, that is a grating sensation against the vertebral bodies. It should be checked, and we should check for any enlargement of cervical node. So this assessment also involves the outpatient setting. It involves the telescopic Hopkins rod examination with 70 or 90 degree scope. So we have to hold the tongue for examination. Few patients may not cooperate for this one, and so it actually gives a superior view. So in such cases, when the patient is not cooperative, also for the better assessment of the larynx, we can go for a flexible laryngoscopic examination. It gives better assessment of vocal cord mobility and better panoramic view of larynx. It also helps to take a biopsy from the lesion. So narrowband imaging, it is an optical imaging tool. It uses filters of blue and green light of 415 and 540 nanometers, which actually peaks the absorption of hemoglobin, which actually penetrates the epithelium and helps to identify the subepithelial vessels. This is actually helpful in those doubtful lesions, very early lesion, superficial lesion, and it can even, from the identification of intraepithelial capillary loops, that nature of the intraepithelial capillary loops can gives a idea regarding the nature of the lesion, and the extensive study has happened on this one. So NEAT type 5 is considered as malignant lesions, more in favor of malignancy. And direct laryngoscopy under anesthesia is important for assessing the extension of lesion. The submucosal spread of disease may not be able to identify in the endoscopy examination. Also, the hidden areas of the larynx and the other subsite and the other area, hypopharynx, postcricoid, and piriform sinus and cervicesophagus, can be examined with a direct laryngoscopy with the NECUS or Jackson scope. And we can do a punch biopsy along the direct laryngoscopy. This function evaluation with flexible endoscopy evaluation of swallowing comes along with the needed when the patient presented with the early symptom but has some symptoms of aspiration, or to cross-check with that, we should go for FEES. And these pulmonary function tests are important for those patients planning for a partial laryngectomy. So coming to the imaging, so we knew that in the early laryngeal cancer, we can get a better diagnostic evaluation with an endoscopy. So this cross-section imaging, it gives a complementary tool because it helps to assess the deep spaces. It helps to assess the cartilage invasion and also the neck nodal invasion. Also, the submucosal extension of the disease is better identified through a cross-sectional imaging. So this is a landmark study of Minerva Becker. So they preferred for a contrast enhanced CT with high resolution images, and it is contrast enhanced MRI is opted only in doubtful cases of cartilage invasion, which is not identifiable in contrast enhanced CT. CT we prefer to be in quiet breathing rather than in dyspnea, so apnea, because the quiet respiration, we could easily see the anterior commissure and posterior commissure areas, and we can go for the manuals like phonation and Valsalva manuals for assessing the ventricles and hypopharynx. So assessing the pre-epiglottic space, because the pre-epiglottic space, paraglottic space invasion enroll, it will upstage the tumor staging. So it has pre-epiglottic space invasion. Both CT and MRI has got an 100% in sensitivity according to these landmark studies, and the specificity is around 90 to 93%. And in the paraglottic space, sensitivity comes around 93 to 95%, but specificity is on the lower side. This may be attributable to the peritumoral inflammatory changes that can actually overestimate the tumor spread and gives a false positive report. So this is an axial image of the normal glottis, and the other one is subglottis. Any submucosal tissue in the subglottic area should be considered as suspicious. Also in the anterior commissure and posterior commissure area, any submucosal tissue or submucosal thickening, we should take it as a suspicious. So coming briefly into the staging, so the TIS carcinoma in situ, coming into the supraglottis lesion. T1, it is a tumor which is limited to the one subsite of supraglottis with a normal vocal cord mobility. And T2 is the tumor which invade the mucosa more than one adjacent subsite of supraglottis or glottis, or a region outside the supraglottis that can be mucosa of the base of tongue, vallecula, medial wall of piriform sinus without fixation of the larynx. We will be mainly dealing with the T1, T2 lesions. Coming to the glottis, the T1 lesions of glottis again subdivided into T1A, which is involving limited to the one vocal cord, and T1B when it involves the both vocal cord, and T2 when the lesion extends into the supraglottis and or subglottis and or with impaired cord mobility. Subglottis, though the carcinomas are rare, the T1 is tumor limited to the subglottis, and T2 tumor extend to the vocal cord with normal or impaired mobility. So the nodal staging is similar to that of other head and neck carcinomas, and T1 and T2 N0 lesions are considered as stage 1 and stage 2. And we can, before going into the treatment, we can just see what the NCCN says. So carcinoma glottis T1, T2, N0. Those carcinoma in situ cases, we can go for an endoscopic resection. The preferred modality is endoscopic resection. Then the other modality, it can be treated with radiation also, especially when there is endoscopic resection is not feasible, or in case of recurrent lesions. And those lesions which are amenable for preservation, we can go for radiation or endoscopic resection or an open resection. And the other adjuvant treatment is depend upon the pathological report. Coming to the supraglottis, here the T1, T2 lesion and N0 lesion and the T3 patient, selected T3 patients can be treated with an endoscopic resection followed by a neck dissection. Neck dissection is because supraglottic cancer has got a high chance of nodal metastasis. T1 has got a chance around 20% and T2 has got around 35%. So we can go for an endoscopic resection of primary lesion along with the neck dissection. Most of the time, we should go for a bilateral neck dissection, or we can go for an open partial laryngectomy with neck dissection, or it can be treated with a definitive RT. The adjuvant treatment depends upon the pathological treatment, pathological report. So our treatment options available are transoral laser surgery, radiation treatment, and open partial laryngectomy. I will be concentrating on the transoral laser surgeries and radiation treatment in early laryngeal cancers. So the factors, before going into the topic, the factors which can influence the treatment decisions, we all know that there will be patient factors, tumor factors, as well as treatment factors. So patient factors, the age, comorbidity, the performance status of the patient, also the patient's wishes and patient's choice also important for here to choose the modality of treatment, and the follow-up also important. The tumor factors, the subsite involved, the extent of tumor involved, and the histology of the tumor, the anterior commissure involvement, all helps to takes to decision on the treatment decision. So the treatment factors, the cost of the treatment, the infrastructure available in the treating hospital, the expertise available, and the institution protocol. So according to the institution protocol, the treatment decision varies. So transoral laser surgeries, previously the laryngeal lesions were managed with cold steel techniques to some extent, and later the Stewart and Strong introduced the laser for the resection of the carcinoma in situ. And from this, the Professor Steiner, he got by seeing the result, this Professor Steiner started introducing the laser microsurgery for resecting the laryngeal carcinomas. And it was between 1979 to 1991. This article was published in the year 1993. So from his study, we got a new technique as an adjunct tool for radiation therapy in treatment of early laryngeal cancer. So in case of going into the transoral laser surgeries, which all lesions are amenable for a laryngeal surgery? We can excise the T1, T2 glottic cancers, supraglottic cancers, and selected T3 lesions, as well as we can excise the pre-malignant lesions. The other thing important is non-squamous carcinomas can be addressed with the laser surgeries that may not be easily amenable to the radiation. And also the recurrent cases and residual cases can be managed with the transoral laser surgeries. And so coming to the classification in the glottis, and European Laryngological Society, they had divided into the into the 6 types. One is subepithelial cordectomy, where we are we are removing the epithelium of the vocal cord. That is in the early stage of the applicable for early laryngeal, early glottic vocal cord carcinomas. And the subligamental cordectomy, here we are resecting the epithelium and the vocal ligament through the ringy space and vocal ligament. And the transmuscular cordectomy, we are removing the resection of vocal fold down into the vocalis muscle. And the type 4 is the total cordectomy. Here we are resecting the entire cord, which extends from the vocal process of the arytenoid till the anterior commissure. Here the margin is taken as inner margin, either include the inner perichondrium of thyroid cartilage or up to the inner perichondrium of thyroid cartilage. Coming to the extended cordectomy, where extended cordectomy is a total cordectomy, along with if we are removing the anterior commissure and part of the contralateral fold, it is type 5A. 5B when we resect the arytenoids, and 5C is when we the total cordectomy if the resection includes the subglottis, and 5D when the resection involves the ventricle and false scope. Type 6 is the anterior commissurectomy. So next, going into the European Laryngological Society classification for supraglottic carcinoma, it is again four types are there. Type 1 is limited excision. Limited excision is for the superficial lesions. So it can be anywhere, the lesion can be anywhere, and it is very superficial. And type 2 is medial supraglottic laryngectomy with partial resection of preepiglottic space. So type 2A means partial resection of preepiglottic space with the suprahyoid epiglottis, and type 2B partial resection of preepiglottic space along with the total epiglotectomy. Type 3 again medial supraglottic laryngectomy with resection of preepiglottic space. It is again of two types. When we are resecting when the tumor is extending into the petiole. Petiole is the lowermost part of epiglottis. So we will be excising the entire epiglottis, and the entire total preepiglottic space will be excised. Type 3B means tumors involving the infrahyoid epiglottis as well as the ventricular fold. So the ventricular fold is dissected off from the thyroid cartilage. Then type 4 is the lateral supraglottic laryngectomy. When the type 4 is when the tumor involves the threefold region, we'll be removing the array epiglottic fold, the pharyngoepiglottic fold, and the ventricular fold. And the 4B, the tumor is extending into to the arytenoid, and so the resection involved the arytenoid as well as the medial or the anterior wall of the pyriform fossa. So what are the advantages of transoral laser surgery? So transoral laser surgery, it is a single sitting procedure. It can be done on a daycare basis or on a overnight admission basis. It usually very less effect on the swallowing and breathing. So tracheostomy and nasogastric tube insertion is requires in very rare circumstances. But what are its? There are some limitations for the transoral laser surgery. So the
Indu, your slides are not moving.
Awesome.
Oh, yes. No, I think there is something.
It's actually, sir, I just wanted to
Okay.
certain touches.
Okay.
So the limitation that the patient factors, the patient mouth opening, the dental, any prominence of the dental arch, any history of any severe cervical spondylosis, any previous history of irradiation to the neck, all these are important because it will affect the exposure of the larynx. So the exposure of the larynx and the anterior commissure area, the entire exposure is adequate exposure is a major factor needed for the proper transoral laser surgeries. And the other factors, other thing is, so just briefly about the procedure, before when we go, so before going into the transoral laser resection, we should adequately, the laser protective measures should be adequately maintained. Then we can use a suspension laryngoscope to visualize the larynx with the help of operating microscope, which is coupled to a laser machine, can be used for excising the lesion. And it is usually with the lesion can be excised as a monoblock, or it can be taken out in fragments. And it is important to orient the specimen properly to the pathologist over a paraffin block, or it can be over a dried up cucumber in the proper anatomical position, and we can send it for a frozen. And in the laryngeal cancer, 1 to 2 millimeter margin is considered as adequate. And even in the case of close margin or positive margin, because there is chance for charring of the margins when we take out with the help of the laser. So if the surgeon is confident enough on his margins, the lesion, even if it comes as a closed margin or positive margin, we can very well keep under follow-up. And we usually use the carbon dioxide laser for the excision of the lesion. It has a 10,600 nanometers, and it is an excellent cutting tool with less coagulation ability. Going to the radiation treatment. So the radiation treatment, it was delivered by using mega voltage photons. The target volume actually according to the primary lesion. In the case of glottic carcinoma, regional lymph nodes are not treated as it has low risk of lymph node mets. In T1, glottic carcinoma has less than 5% and T2 has 7% chance of lymph nodal mets, and that too it is differ according to the institutional protocol. Some institution can even include the regional lymph nodes in their radiation field. So the treatment is usually delivered through two lateral field, which is covering the laryngeal skeleton from the thyroid notch to the inferior border of cricoid. The field size varies according to the extension of the tumor. And the most commonly used fractionation regime is 50 to 55 gray in 16 to 20 daily fractions over 3 to 4 weeks. So this is a study by Yamazaki published in the year 2005. So this is actually a prospective randomized study on fraction size. So what they found is over the 5-year follow-up, the local control rates were significantly better in those patients treated with 2.25 gray per fraction with no difference in acute or late toxicity compared to that of 2 gray per fraction regime. So coming to the supraglottis, here the target volume encompasses the primary tumor along with the lymph nodes bilaterally 2 to 4A. And because even if there is clinically or radiologically no lymph nodes, we should include the lymph nodes in the radiation field because of high chance for occult nodal metastasis. So the fractionation regimen, similar to that of the glottic carcinoma, usually alternative regimen is available of 65 gray in 30 fraction over 6 weeks. So coming into the those articles which is comparing the comparing the carbon dioxide laser microsurgery and radiotherapy in glottic cancer. So here our treatment is basically based on the retrospective studies rather than on prospective studies. The prospective and randomized controlled trials are almost rare or very less available in these topics because the treatment is usually a patient choice or usually surgeon's choice. It is difficult to randomize into either of the arm. So it will be decided on the different factors. So this systematic review by Vakulik et al., which is published in the year 2021, and they found this primary therapy with the transoral laser is equally efficacious as radiotherapy in local control. So we're going into their results. So in the this forest plot, we can see the overall survival favors that of a transoral laser surgery. Always the overall survival is a debatable between the radiotherapy as well as in the laser settings. So, but what they mentioned is after including the recent studies, what they found is that overall survival is more favoring towards the transoral laser resection. Coming to the disease-specific survival, it definitely favors with the transoral laser microsurgery. And the laryngeal preservation was found to be better with the, again, significantly better with the transoral laser surgery compared to radiation therapy. But the local control, there is no significant difference observed between two arms. Coming to the voice outcome, so always when we opt a treatment, we always consider the functional status. So the voice is one of the major factor determining which treatment to be opted. So the voice outcome, this is Grulich et al. So published in the year 2015, it is a systematic review and meta-analysis included 362 patients with a follow-up of 47 months. So they compared the voice outcome with voice handicap index. What they found is there is no significant difference between the RT and laser arm T1 glottic cancer. Usually it is said that a voice is better with the radiation treatment, but according to this study, there is no significant difference between radiation and laser. So this meta-analysis by Huang et al., they included 2 prospective and 7 retrospective studies. So it is again on the oncological outcome. So they did not find any statistical difference between the 2 treatment modalities in local control, overall survival and disease-specific survival. But they found a significant better laryngeal preservation with the laser surgery arm.
Very well done, Indu, and very impressive display of the anatomy, especially, and utilization of anatomical knowledge to surgery. I think before we go on to questions, Dr. Sandeep, would you like to make some comments?
Good morning, sir. Sir, actually, am I audible, sir?
Yes, yes, yes.
Yes, sir. So we are talking about early laryngeal cancers here. So as Dr. Indu discussed, the options of radiation versus surgery are always there. What I would like to speak is like the experience at our institute with regards to early laryngeal cancers. Primarily glottic cancers, what we usually do is when a new patient comes to us, we clinically examine, we stage the patient, we do imaging for almost all laryngeal cancers and make sure the staging is done appropriately. And if it is a glottic cancer, which is amenable for a laser surgery, we explain to the patients regarding the different options. We give them the options of laser as well as radiation after taking into all the consideration that Indu said. You have to take into consideration the tumor factors, the patient factors, lot of matters have to be taken into consideration. And then we even explain, one thing I would like to stress is that cross-sectional imaging is a must for all early glottic cancers, even T1 lesions, because Dr. Indu said that some lesions might masquerade as a T1 lesion. They might be eroding the inner cortex of the thyroid cartilage or even maybe going beyond. So what we feel is that cross-sectional imaging is a must for all even T1 lesions before thinking about laser surgery. After that, we do send them to the radiation oncologist. They explain regarding their treatment, their point of view. And many often what happens is that the patient, obviously, when we say that it is just a one-day procedure, the expenses are such, within one day the treatment gets over, the patient might obviously incline towards surgery, but we do have to explain regarding the voice that it may lead to a deterioration in their voice quality. And we do explain to all patients that we may not be able to successfully remove their tumor. We may not be able to, because we have had that issue. Many patients, we are not even able to adequately visualize. What we have found is that though many patients preoperatively, their neck might be soft, the hyomental distance, malambati grading, we take all that into consideration. But we find that despite giving the adequate muscle relaxation, intraoperative visualization is not adequate if the lesions especially are reaching up to the anterior commissure. So we do explain to all patients that we might not be able to remove the tumor adequately. In that case, they might have to again go for radiation itself. So once all these matters are discussed with the patient, they go to the radiation oncologist, hear their point of view. Then we come to a decision after our multi-specialty tumor board as to whether laser or radiation is to be taken. That's what we usually do at our institute, sir.
Thank you. Any questions are there? One comment has come, class is too fast.
Yes, sir. That what happened was that the topics actually there was surgical anatomy as well as workup as well as management. So Indu wanted to finish off everything, not go beyond the 1 hour.
She has done it very well. I must compliment you, Dr. Indu. Just 2 statements I would like to make, that as a surgeon, especially as a beginner, You must know the anatomy. You must know the anatomy. And study the images well and discuss with the radiologist before you actually put your knife. And then plan your treatment. See the age of the patient, profession of the patient, what the patient is expecting from you, and the comorbidities you have highlighted, and whatever the expertise available in the institution. And I give a lot of importance to the profession of the patient and his expectation. What is he wanting? So I think then only you should plan your treatment. And remember one thing, that decisions are more important than incisions. Remember in life. So most important for any surgeon, for any oncologist, decision making is extremely important than making an incision. Incision everybody can learn, but decision making is extremely important. Okay. So anything more?
Sir, one more thing. Actually, our pathologist and speech therapist also play an important role in the management of. I just wanted to stress that, because we end up sending these specimens for frozen section. We send the rewired margins also to ensure that the tumor has been adequately cleared. So that helps us a lot while managing such cases via laser cordectomy. And obviously, the speech therapist helps us in rehabilitating these post laser cordectomy patients. So it's like a team approach.
Fine. Anything else? Dr. Indu,
Yes, sir.
would you like to make one statement at the end on your talk?
Sir, as you said, we should give the preference to patient choice, and that will be the best deciding factor in early laryngeal carcinoma. I feel so.
Okay. Thank you. And wonderfully presented.
Thank you.
Very impressive. You've covered almost everything in early laryngeal cancer. Well done.
Thank you.
Thank you.
Thank you, sir.
Navneet ji?
Sir, thank you. Thank you very much, trainees and faculty members, for joining the session.
Thank you.